Bismillahirrahmanirrahim. Subhanallah walhamdulillah wa la ilaha illallah wallahu akbar. La hawla wa la quwwata illa billahi al-aliyyil azim. Allahumma salli ala Muhammadin kama tuhibbu wa tarzalu. You all are welcome on behalf of iHeart and Ferozsons Pakistan Limited. My name is Muhammad Shahid Farooqi and I am a member of Ferozsons family. I would like to appreciate all the doctors who are attending to the seminar. You have been spending your valuable time. And Ferozsons also would like to a special thank to all the doctors community who are doing extraordinary job in this scenario. They are putting their life in the danger zone, but they are saving the whole nation. Ferozsons salute all of you for your services. I'm sure we all will together can save ourselves and the nation. And by your help, we will continue to defeat coronavirus. We are going to start our program. And to start my program, first I would like to hand over a mic to Dr. Shaila Naseem. Dr. Shaila Naseem is a family physician. She's also a member of College of Family Medicine, and she is also a member of the Ferozsons family as a head of medical affairs. So Dr. Shaila, hand over to you.
Thank you very much, Shahid Saab. Bismillahirrahmanirrahim. I have the pleasure of introducing Professor Dr. Adeel Ajwad Butt. Professor Butt is a very renowned professor of medicine. Dr. Adeel Ajwad Butt is MD, MS, Chair, Institutional Review Board, Weill Cornell Medical College, Qatar. And Professor Butt is a professor of medicine, infectious diseases, and professor of healthcare policy and research at the Weill Cornell Medical College, New York and Doha, Qatar. So I would request Professor Saab to please give his detailed intro. And with this, I hand over the mic to Professor Adeel Ajwad Butt Saab.
Thank you very much. Assalamu alaikum everyone. सबसे पहले तो आप सब लोगों का बहुत-बहुत शुक्रिया. इस वक्त 633 लोग इस वेबिनार पे मौजूद हैं सारे पाकिस्तान से. And like Dr. Shahid Saab pointed out, I would also like to salute you and thank you for your service taking care of the patients of this deadly disease from all over Pakistan. I'm going to start sharing my slides, and Dr. Shaila or Shahid Saab, let me know if it works.
Yes, Doctor.
Can you see the slides now?
Yes, we can see, Doctor.
Okay, I'll make it full screen and let me know if that is also working now.
Yes, it's okay.
Okay, I think something happened out there. Let me go back to the first slide. So I would also like to thank Ferozsons for arranging this seminar. And I know they have reached out to a lot of you, and you have taken times out of your busy schedules to attend this. So for that, both Ferozsons and I thank you very much. I have no conflict of interest relating to this talk, so I have no disclosures to make. So the outline of this talk is that I'm going to go over a brief history of coronaviruses. We will talk about the epidemiology of the current outbreak. We won't spend too much time on that because I'm sure everyone is looking at the numbers every hour or every few hours or at least every day. We are going to spend a reasonable amount of time on busting some myths. So we will do a quick fact or fiction check of some of the common myths that are floating around over social media. We will spend some time on the treatments that have been advocated and forwarded, and we will go over the evidence of what works and what doesn't. We will finish it off with some diagnostic and prevention strategies related to COVID virus. So in terms of history of coronaviruses, beta coronaviruses are very common in nature. They often infect animals, and 7 species have been known to infect humans. Now, we know SARS coronavirus and MERS coronavirus as the most known ones, and now the SARS-CoV-2, which we are going to talk about today. But there are at least 4 other species which don't have a specific name but are designated by specific numbers. The first three that I talked about, the SARS corona, MERS corona, and SARS coronavirus 2, cause severe disease in humans, while the other ones are associated with much milder disease. If you remember, in 2002, a large epidemic started in China and lasted about a year, and then there were sporadic cases thereafter. This epidemic infected about 8,100 people worldwide, of which 774 died. But in 2003, this outbreak was declared to be over, and we haven't seen a large outbreak related to that original SARS coronavirus since then. MERS coronavirus started in about 2014-15 era, and it has infected a total of 2,500 plus patients now, associated with 858 deaths. And we're having some sporadic cases still around the globe. I investigated the first outbreak of MERS coronavirus in Abu Dhabi and the United Arab Emirates. And then most recently, I've still seen a case about 2 or 3 months ago in Qatar, after a break of about 2 to 3 years or so. So sporadic cases of the MERS coronavirus are still occurring. In terms of SARS-CoV-2, this is the 7th coronavirus which has been known to infect humans. Now about the nomenclature, or how do we name it? So the virus has been named SARS-CoV-2. The disease that this virus causes is called COVID-19, or coronavirus disease, and the 19 refers to the fact that the first cases were identified in 2019. It has a receptor binding domain with high affinity for ACE2 receptors in humans and several species of animals, which include ferrets, cats, and some other animals. And genetic data has shown clearly that SARS-CoV-2 evolved naturally from existing coronaviruses which were infecting animals, and it is not derived from any virus in the lab. But how did it jump into human population? There are two scenarios that we think have happened or could have happened. Scenario one is that there was natural selection in an animal host before the zoonotic transfer occurred. And some evidence to that effect comes from the fact that many early cases in China were linked to an animal market in Wuhan. There is a lot of similarity with certain animal coronaviruses like bat SARS-CoV and the pangolin SARS-CoV, but there are small differences as well in their receptor binding domains and in the cleavage sites. Now, people can go back and do genetic sequencing of the virus and these domains, and that can tell us quite well whether these viruses evolved in humans or animals, or whether they were derived or created in a lab. And data clearly shows that there's no evidence that these viruses were created in a laboratory as a bioterrorism agent. They evolved as natural selection over a period of time within either the zoonotic or the human population. And the second scenario is that some earlier form of SARS-CoV-2 jumped from an animal species into humans. After that, it developed some mutations which made it effective to move from one human to another. And when this became large enough, then the epidemic was picked up in humans. This is an epidemiology graph or epi curve of the COVID-19 epidemic. And I'm not going to go into the detail of that, except pointed out a couple of things. That the first cases were identified in early December. By end of December 2019, China had declared a major outbreak, started investigating, and closed the market where this outbreak had occurred. Within the next 4 weeks after that, which is about 6 to 8 weeks after the start of the epidemic, Chinese scientists had sequenced the virus completely. And the wonderful and great thing that they did was they shared the sequence with every researcher in the world. They did not keep it to themselves, they shared it in the world. And that has helped significantly in terms of developing, understanding the virus, its pathophysiology, and how it has been transmitted. Now, as for the situation report, I prepared this slide earlier on in the day, and there were 1.1 million cases. I updated that about half an hour ago, and this number may have increased even further in the last half an hour. by 8 p.m. Pakistan time, there were 1.153 million cases that have been reported with over 61,000 deaths. Now, this is a graph. I'm going to pause here for a second and ask the moderators, okay, I'm having significant difficulty and there's a lot of markings on the screen. Is everyone else seeing that as well? Can someone hear me?
Yes, Dr. Saab.
ये screen पे ये बहुत markings वगैरह आ रही हैं. I'm not sure where they're coming from. Is it something that you see as well?
Yes, this is also our side.
So I'm not sure where this is happening. So I think it's disturbing for the attendees as well. Is there any way to find out what's happening here?
Okay, yes,
Okay.
Hello.
See, I'm trying to share it again. So maybe you should take control for a second and then I'll redo that.
Sure, sure.
Because I can't seem to control this right now.
अदील साहब दोबारा शेयर कीजिएगा जरा.
जी मैं अब दोबारा शेयर करता हूँ अपना स्क्रीन अपनी. Is that better now?
Yes.
चलें. So बहुत माजरत तमाम participants से. Very sorry about this technical glitch. I'm not sure what happened. लेकिन अब जरा screen clear हो गई है. So this graph shows the total number of cases globally. And you can see that there's been an exponential rise in the last 1 month or so, and we'll talk about that a little bit. This is the number of cases seen per day, number of new cases seen per day in the world. So यहाँ पे in the first part is mostly cases seen in China, and the later part is the rest of the world, and hardly any cases being reported from China at this point in time. And this time period in between is when Chinese cases had dropped very significantly. The epidemic or pandemic had not taken hold in the rest of the world, but the world was caught asleep and they did not have a robust response to this infection. This is the scenario in China. And the reason I show this is that they were very effective in controlling this pandemic. As you can see, this line flattened out after about less than 2 months or so. And the number of new cases dropped very significantly, and now they are hardly reporting any new cases from within China. Now, I show this slide to compare 3 most affected countries in the world and compare that with Pakistan's situation. So USA, as you know, has the highest number of cases at this point in time, followed by Italy and Spain. And you can see the number of cases is rising very, very dramatically in the US by tens of thousands of cases every day. In Italy, the cases had gone up exponentially, but it seems like they have plateaued and even maybe started to come down. In Spain, again, they had a sharp uprise of cases, but they seem to have plateaued. In Pakistan, the situation is a little more unclear because there are spikes and dips and ups and downs. And I think this is because when there is a test drive, a lot of testing being done or contact tracing is done, the number of cases goes up. And when there is a lapse or a slowdown in number of tests being done, the number of cases also goes down. And this is important in figuring out the strategy we need to implement in Pakistan to control this epidemic. This is again a comparison, but this comparison was done about 1 week ago, so the number of cases is not correct. The number has increased, but I think the message is still clear that there is a difference in mortality in various countries, and we can talk about that, why there is a difference in the number of deaths being reported. Part of it is because of demographics, because older people are more likely to die. And for example, in Italy, a vast majority of the population is more than 65 years old. But I also try to correlate this with the number of ICU beds per 100,000 population in each country. As you can see, countries which have the highest number of ICU beds have relatively lower mortality, probably because the sick people are being taken care of on the ventilators and in respirators in ICU settings. And in countries where there is not enough capacity, there are more people, unfortunately, who are succumbing to this infection. So let's spend the next few minutes busting some myths and try to play this fact or fiction game. So the questions, these are based on a lot of questions that are going on around on social media, as well as I getting asked about these questions and trying to set the record straight. So first thing is COVID like the regular flu? And the fact is that COVID-19 is more infectious than regular influenza, and it is more lethal than the regular influenza as well. However, it is less lethal than SARS or MERS coronaviruses. So this is the evidence to show you or convince you that this is more deadly than influenza, but has lesser mortality than MERS coronavirus and SARS coronaviruses. As you can see, case fatality rate for COVID-19 is under 5%. For SARS, it was 10%, and for MERS-CoV, it was 35%. For influenza, at least in the US, the mortality is less than 1%, a fraction of 1% over any given season. Young people seem to believe that they will not get the infection and they will be free of this. However, this is a myth as well. It is well known that COVID-19 is more likely to cause serious illness and death in older people, and also those who have chronic medical conditions like chronic heart disease, diabetes, chronic kidney disease, liver disease. But several cases have been shown to occur in younger people, and many deaths have occurred in the younger population as well. It should also be noted that young people play a very important role in transmission of infections. It's not just that they will get infected and may not have severe consequences, but they will pass it on to other people in their family, among their friends, and there may be other people in the family who are older and have medical problems who will die from this disease. So this is the evidence that while mortality is highest in the older people, even in people who are 20 to 30-year-old, about 0.2% of them die from this disease. And this is higher than influenza, by the way, which is 0.06%. There are a lot of social media posts going on claiming that a vaccine has been found or is about to come out. This is not quite true. The vaccine trials have started, and a lot of patients have now been enrolled in the first few trials. However, a safe and effective vaccine is probably about a year or so away. I think this will be expedited by many countries. A lot of regulatory hurdles will be removed, but it is still several months away before we test it and make sure it's safe and effective. Again, a lot of these myths and totkas are going on around on the internet that you can protect yourself by swallowing or gargling with bleach or salt water, ya garam pani ke gharare kare, or applying hot air to your mouth through a hair dryer or so forth. So this is very incorrect. Saltwater gargling may provide some symptomatic relief, but none of these remedies has any effect on the virus in terms of killing it or reducing its amount. And certain things like bleach can actually harm your esophagus and your mucosal membrane significantly. So please do not try that, and do not share those or tell others to try that. Another myth, which is unfortunately being perpetrated by some very high-profile personalities in Pakistan and other places, is that the coronavirus was deliberately created in the lab and released by some governments as a bioterrorism agent. This is incorrect. There's absolutely no evidence of this to be true. In fact, a recent paper in a very major medical journal has debunked this myth by doing genetic sequencing and comparing that sequences with previously existing viruses. And it shows that this virus evolved from existing natural virus and was not created in the lab. People ask me if ordering and buying products shipped from China will make a person sick. Again, there is no evidence at this point in time of any transmission through trade or trade goods. In fact, the infection rates in China are much lower than the rest of the world at this point in time. So it does not really make sense that anything coming from China would transmit that infection. A very common myth right now is that virus will disappear in summer, so we will just have to wait for the temperatures to go up and things will become better. This is false as well. It is true that many respiratory viruses are seasonal. For example, influenza virus is more common in winter. But that is more because of the fact that it survives better in low humidity, and there is more human contact in winter months because people are huddled together in small group, in closed rooms more commonly. COVID-19 has been reported from 203 countries and territories. Many of these countries have hot and warm temperatures. For example, there are cases from south of the equator. There are more than 5,000 cases in Australia and many other countries where the temperatures are quite high. So there is no reason to believe that the virus will die just because of summer temperature itself. But also has to remember that all infectious disease agents, or almost all of them, are heat sensitive. In other words, if you boil them or if you raise the temperature very high in cultured mediums, they will die. But to achieve that in a human being, you'll have to raise the temperature of the human being or the ambient temperature of the environment to about 60, 70, or 80 degrees centigrade, which is not compatible with human life. So this will not happen because of summer coming, but it will probably happen because of other factors related to the virus, virologic factors. I've seen a lot of spraying of body and streets with alcohol or chlorine or even water, and people think that this is a very good thing because it'll kill the virus and then you won't get the infection. This doesn't make much sense either. Spraying your whole body or streets will not kill the virus that has already entered your body. Also, these chemicals may cause severe skin and mucosal irritation. Finally, it is also impossible to cover every part of your body or all your clothing or all outside surfaces, example, streets or desktops, every single inch to make sure that the virus, all viruses kill. So doing that probably does not make sense at this point in time. More recently, a lot of social media posts are claiming that countries with high BCG vaccination rate or malaria are protected. So it doesn't appear to be so. It seems that there is an association of certain countries where the risk or incidence is lower, but it is also clear that there are so many other factors in play in those countries. So I created this table earlier on today, where I tabulated BCG coverage by country, the number of tests for COVID being done per million population, and the actual number of cases per million population. And it seems relatively clear that even countries with very high BCG vaccination rate, for example, Iran, has a very, very high COVID incidence. And countries with a certain low incidence rate are also not spared. So there's better correlation between the number of tests being done rather than BCG coverage in that country. How does the virus spread? Now, the virus is spread via droplets, and it has also been shown that virus survives in aerosols. So in other words, when you sneeze or cough, these droplets drop on surfaces or your hands or your clothes, and when your hands touch other surfaces and then you touch your mouth, then you pick up the virus. What is troubling is that we've also seen the virus to survive in aerosols for up to 3 hours or so. So they can stay suspended in air in aerosol form up to 3 hours, and people walking in, coming very close to people with infection who have generated these aerosols can get infected. On copper surfaces, virus can stay alive for up to 4 hours. On plastic or steel, it can stay alive for 2 to 3 days or so. There is also asymptomatic carrier transmission, and I think we're getting more and more data about this now. It has been suggested that up to 1/4 or 20 to 25% of the cases may be asymptomatic, and they may play a major role in transmission of this infection to other people. Now, since we are all healthcare workers out here, I think this slide is important for us. That what are the risk factors for healthcare workers to pick up COVID-19 infection? And it seems like one of the strongest factors is someone a family member who has been diagnosed with the infection, and suboptimal use of hand hygiene products before you come into contact with patients. These seem to be very, very important for doctors or nurses to pick up infection. Having a patient with the COVID-19 is less likely to give you infection than these other factors. I think the reason for that is that even though doctors have a critical shortage of protective equipment like masks and gowns, but when they do see patients who they know has COVID-19 infection, they still take other precautions like very meticulous hand cleaning. When they go back home, it may be that they're not being as careful. This gives us a message that when you leave the hospital and come home, you have to disinfect yourself very properly and thoroughly, and also that you have to continue doing hand hygiene before seeing every patient in the hospital. This paper just got published yesterday because there is a lot of controversy whether face masks are needed for the general population or not. It seems that surgical masks do decrease the risk of live virus being aerosolized or generated in droplets. This is not a human-to-human study, but more of a controlled study in a laboratory setting. It does give some evidence that the virus can go down in numbers if you wear a surgical face mask. So previously, CDC and WHO did not advocate the use of surgical masks for the general population. And I think the reason for that was the number of infections in any given community was not large enough to warrant that. I think that recommendation is changing in many countries. Wearing a surgical mask has been suggested to be an effective way of controlling the transmission. How does the infection present? Remember, fever may not be present at admission in all cases. Only half of the people at the time of presentation have fever, but they do develop fever during the course of the illness. 90 to 98% of them develop a fever. The other common symptom is cough. Sputum production, shortness of breath, sore throat, these are all much less common, but do occur. So someone may present with atypical features or so, but fever and cough are the two most common symptoms. Those who develop pneumonia are even more likely to have fever and cough. The cough is productive only in about half of the patients. Shortness of breath may not be present in all patients. People who have comorbidities like hypertension, diabetes, heart disease, liver disease are at high risk of developing pneumonia. And once people develop pneumonia, the chance of them developing ARDS or acute respiratory distress syndrome is about 41% or so. About a quarter of the patients with pneumonia will go on to require ICU admission, meaning they might go on a ventilator. And about 1/5 of these people with pneumonia will die. 22% of the people die once they develop pneumonia. Within the ICU community, once you're admitted to the ICU and on a ventilator, the mortality rate is about 50% or so. The risk factors for death I mentioned previously are advanced age. So if you're more than 65 years old, you have a much higher risk of death. People who have comorbidities like hypertension and diabetes have a high risk of death. There are some laboratory features that may identify people at high risk, but these are not specific to COVID-19 infection. These are related to any infection. So for example, C-reactive protein or coagulation disorders or D-dimer, which are indicative of any severe infection, are associated with the high risk of ARDS and death. So this is a summary of risk factors for severe disease, old age, diabetes, hypertension, chronic kidney disease, chronic lung disease, chronic liver disease, or any condition that reduces your immunity or renders you immunocompromised. I just added this slide for case fatality rate, and it varies from country to country. I don't think we have the time to go into the reasons for why it is so different from one country to another, but suffice it to say that it is very difficult to compare these rates from one country to another because of the reporting differences, because of the differences in definition of deaths related to COVID versus non-COVID related death, etc. But certain countries do seem to have a low rate even after adjusting for those factors. For example, Germany has had a very low rate of deaths related to this. and probably because they picked up and instituted strong measures much earlier than other countries did. It has been shown that if you institute measures of quarantine and social isolation or social distancing before you have a death rate of 0.02 per thousand population, you will be successful in controlling the epidemic. And Germany did that much before that. However, their neighbors, Italy and Spain, waited about 4 to 6 days after they crossed that threshold, and therefore they saw much higher rates of mortality in their population. How do you diagnose a COVID-19? So the most commonly used and recommended thing is to do a nasopharyngeal swab, and I'll show you some data in the next slide. Lower respiratory secretions like sputum and bronchoalveolar lavage, particularly bronchoalveolar lavage fluid, is much more sensitive in picking it up, but it is not recommended at this point in time because BAL or doing a bronchoscopy generates a very strong aerosols and is a very strong risk factor for transmitting infection to healthcare workers. So unless a bronchoscopy is really necessary for some other reason, we don't encourage that for purely diagnostic purposes. Now we also have serologic tests which can pick up antibodies, both IgG and IgM. These are rapid tests and can be done at the point of care and can give you results within about 30 minutes or so. There are more assays being developed, both antigen-based or antibody-based tests, which will be coming to market very soon. Some centers have added chest X-ray or CT scan to their workup algorithm. I don't think we need to do a chest X-ray or a CT scan to diagnose COVID-19 infection because X-rays or CT scans, they show pneumonia. They do not show the causative organism. So if you're suspecting pneumonia in a patient, then it is important to do a radiographic study. If the patient is asymptomatic, probably not really warranted or needed at this point in time. This slide shows the sensitivity or the positive test results based on which sample you take. So nasal swabs, which is what we do most commonly, about 63% are picked up compared with 93% BAL fluid pickups. Sputum is also as good as nasal swabs, but not as good as BAL fluid. Remember, the virus is not picked up in blood or urine, but sometimes can be picked up in the feces. This is a kinetic curve which shows the viral load, natural history of the infection in terms of viral load in nasal swabs, throat swabs over a period of time. And I show this because this will be important when we try to interpret the clinical trials for various drugs. Now you can see that the viral load goes down to very low or undetectable levels over a period of 6 to 10 days or so. This happens even without giving any treatment, and this is important to remember. Now moving on to treatment, a few days ago, about 4 to 5 days ago, FDA in the US issued an emergency use authorization to allow chloroquine and hydroxychloroquine for the treatment of certain patients with COVID-19 infection. However, this authorization does not include its use as prophylaxis. This is the only drug that has been approved for an emergency use authorization. No other drug has been approved by any agency in the Western world at this point in time. One should also be careful that FDA has not endorsed its use completely. They have mentioned that it is some early uncontrolled trials show benefit, but more data is needed to understand that. And this is what I'm going to show in the next couple of slides or so. Other than that, the backbone or the cornerstone of treatment is supportive treatment, depending on the severity of illness. So before we go into some data about that, I think I like showing this slide of what is being posted on social media. Various treatments being proposed are not really helpful. Kharbuza certainly does not cure coronavirus, or what this Pir Saab was saying about the stomach lining of pigeons or kabutar ke pote ki jhilli is a final cure for coronavirus is not true. Similarly, gaur mutar, which is being advocated in India, is not a cure for coronavirus. This is a list of things or agents that have a possible role. So chloroquine with or without azithromycin, convalescent plasma or serum, remdesivir, IL-6 receptor blockers, and I might move ivermectin, which is an antiparasitic agent, to this group based on the paper that was published yesterday, and I'll show you those data as well. It just came out this morning. There is no role for steroids, ACE inhibitors, oseltamivir, lopinavir, ritonavir, unless there is a need to give them for other conditions. We're unsure what the role of interferon, ribavirin, non-steroidal anti-inflammatory drugs, vitamin C or zinc is at this point in time, because they do not kill the virus and do not lower the viral load. Some of these may have symptomatic treatment roles, for example, zinc, vitamin C, and non-steroidals, but they do not do anything for the virus itself. This is the study that generated tremendous amount of enthusiasm and interest globally, after which the President of the United States and many other advocating chloroquine, hydroxychloroquine, to be given to everyone who is suspected of having COVID-19. This was a study of only 30 patients, of which 20 were in the active treatment group, and they showed that by day 5, all of them had undetectable virus in the nasopharyngeal swabs. A very small number of people, which was not selected randomly, did not drop their virus to that level or so. So remember, there was no proper control group. There was varying disease severity, and there was no randomization of people. This was just an observational study of a very small number of people. The same group published a follow-up of this study a few days ago, and I summarized the study design. They also had a very loose definition of who was included. So everyone who had either an upper respiratory infection or a lower respiratory infection and had COVID-19 was included and given hydroxychloroquine and azithromycin. Their outcomes were 3. One was someone developed an aggressive course of disease. In other words, someone required oxygen, which is a very, very loose requirement, or an ICU admission. They also measured contagiousness by measuring the amount of virus using PCRs and length of stay in the infectious disease ward. Now, these are the characteristics of the patients that they included. There were 80 patients, 80. 41% had upper respiratory infection alone with very mild symptoms. About 54% had lower respiratory infection. But even when people with low respiratory infection or pneumonia were mostly asymptomatic or had very low severity of disease. So 92% of the patients at the time of admission had very mild disease, a very mild illness, and at discharge, this number was not any different. They showed that the viral load dropped in a fair number of patients over a period of time. But remember the slide I showed you earlier about viral kinetics. Over a period of 5 to 10 days, viral load drops in most patients regardless of whether you give treatment or not. Also, you can see that these light colored bars are the number of patients, or these black bars are the number of patients being tested at each time point. So the number of patients being tested goes down over the course of the study. So if I was to summarize that, I have a lot of concerns about the studies. It had no control group. There was varying severity of disease, and most of the people had very mild disease to begin with, and they were expected to recover without any treatment anyway. It is not clear what other treatments they got. It seems that they were allowed to get any other treatment that the doctors think were okay to give. There was no change in disease severity from the time of admission to time of discharge, and even patients with pneumonia had mild disease to begin with. So while this gives us a signal that this drug combination may be helpful, this does not convince us in any way, shape, or form that this is the silver bullet that will cure COVID-19 infection. We really need a well-done randomized controlled trial to understand this. And the good news is that those trials have already started, and we should get some results over the next few weeks or so. Remdesivir, which is an antiviral agent, has been shown in vitro, meaning in laboratory, to decrease the viral load significantly over a period of few days. This is in clinical trials as well. There's very little human data on remdesivir, but trials are ongoing. This drug is made by Gilead, and they are recruiting from many sites over the world, across the world. Lopinavir ritonavir is an HIV drug combination, which was shown to have some activity in in SARS, earlier in SARS epidemic and in MERS-CoV, but the improvement was mild at best. There was a better study done to look at the role of lopinavir/ritonavir. It was a randomized trial of about 100 patients in each group and did not show any improvement in clinical parameters and did not show any change in viral RNA from study enrollment to study end. So in other words, this was a large enough study but did not show any benefit, either clinical or virologic. So based on that, I moved this to the column where it has probably no effect on COVID-19. A paper was published about 5 days ago using convalescent serum and showed that plasma transfusion can significantly decrease the viral load in patients with COVID-19 infection. However, this study was only done on 5 patients. There was no control group again, and these patients all received multiple other treatments like antivirals as well. So it is unclear whether they got better because they got antivirals or some other treatment, they was going to get better by themselves, or was it convalescent plasma or serum that helped them. But there is a signal out here, and I think there are other trials ongoing to understand the role of convalescent serum in this population. This ivermectin study is what just came out this morning or last night. Ivermectin, as you know, is an antiparasitic agent which has a broad antiviral activity, has never been used for antiviral treatment. This is a study done in cell cultures in the lab. This is not a human study. It's a small study which looked at the effect or the effect of ivermectin on cell cultures or cell-associated virus. It showed that after 48 hours or so, there was a 5,000-fold reduction in virus in cell cultures. At 48 hours, there was about a 93% reduction or so. There is, again, a good signal in the lab study, but this needs to be transferred to human studies and studied in humans before we can make any judgment whether this is workable or not. Also, we do not know what dose would be effective in humans to be able to kill at this level that we saw in the labs. Tocilizumab, which is a biologic agent, is an IL-6 blocker, has been shown in a subgroup of patients with COVID-19 to have significant benefit. The subgroup is the one who have a cytokine storm, or people who are in the ICU who are very, very sick and develop an IL-6 storm or very high levels of inflammatory markers. In those groups, blocking these inflammatory markers has been shown to have some effect. Again, human studies are ongoing. Early human studies, early phase studies have shown benefit in inflammatory markers like CRP levels and clinical markers like temperature and need for oxygen, as well as oxygen saturation. So we're waiting for larger trials for us to understand the role of this and which group would it help in. This is a suggested triage algorithm, and many of these are available. Every hospital, major institution has developed one of their own. But I think at the center of this is you decide after testing if the person is positive, you decide whether they have symptoms or not. If they have mild or no symptom, either at home, if the home situation is conducive, or in institutional quarantine facilities like we have developed in Qatar. I'm overseeing about 6,000 persons in quarantine right now across various hotels and apartment buildings where we've housed them, and we monitored them for 14 days or so. If they have severe symptoms, they need to be hospitalized, and you need to determine whether they need ICU admission or a regular floor admission. Regular ward admission would be fine, and then you treat them accordingly. This is a group where you would try even experimental treatments as a last resort, what we call compassionate use of drugs, and a lot of people are actually doing that. The middle group with moderate symptomatology is a little more difficult to give any recommendations about whether to treat them with all sorts of drug combinations or not. I think it is mostly left to the treating physician, what he or she decides. This is where the recent clinical trials, which will come out in the next few weeks, are also going to be very, very helpful. How to prevent infection? The most important thing are the two pillars of that. One is you have to prevent yourself from getting infected. And this is not just for healthcare workers, but everyone in the world, every person in the country. And then you have to prevent yourself from giving it to others. if you do both of these things, then we will save the world together. And how do we do that? We have to break the cycle of transmission by these common sense measures which have been shown to be effective. I think there is very little doubt in scientific community that these measures do work, no matter what certain government agencies in certain countries are saying. Social distancing, stopping mass gatherings, staying at home or working from home, immaculate hand hygiene have all been shown to break the cycle of infection. No handshakes, no hugs, restrict travel to absolutely critical travel, avoid any place where there are large number of people gathering, like malls, restaurants, weddings, funerals, mosques, churches, etc., and proper cough etiquette. So all these things have been shown to break the cycle, and the countries who have shown a decline or a stability in number of cases are the ones who started these measures much earlier on, and they have been successful. How do you manage contacts? So you obviously have to do a quick medical evaluation. If the person has come into contact with a confirmed case, then you need to test them by nasopharyngeal swab and isolate them in quarantine. And further management is based on meeting case definition and symptoms. Now, definition of significant contact varies from country to country and authority to authority. Some say that distance of less than 6 feet for 15 minutes, some say 4 feet for 30 minutes is what the limit of significant contact is. But whatever you decide to be significant, you need to isolate those cases who have come into contact with confirmed cases. If someone comes to you who came into contact with someone who came into contact with a case, meaning 2 degrees of separation, we do not recommend a lot of things or quarantine or isolation in these patients at this point in time. We do suggest strict social distancing, hygienic principles, and staying at home, which is true of all patients who are asymptomatic or contacts of asymptomatic people. So this is kind of a summary of these measures, how to implement those. So businesses and companies and organizations need to encourage people, their workforce, to work from home whenever it is possible, using audio and video conferencing for meetings. Do not gather in large numbers in any place, no handshakes, close common areas or avoid common areas like water coolers, cafeteria, if people indeed have to come to work, frequent hand hygiene, and meticulous cleaning of common areas and surfaces. Like if you have an office where many people sat, the table should be cleaned very thoroughly. Now, is there hope that we will come out of this epidemic anytime soon? So this is the slide I showed you earlier as well. So I compiled this data, and this data is accurate as of today. You can, and these are the 3 topmost countries, and I add Pakistan to that for comparison. So you can see a very strong exponential rise in number of cases in the US. But on the other hand, in Italy, the number went up exponentially, just like the US, but then it plateaued, and maybe some evidence of the numbers going down. Spain shows similar things, went up very sharply and has plateaued. They haven't started a downward trend, but at least has plateaued over at least 1 week or so. And I think this gives me hope that if you start to implement strict measures of isolation or lockdown in certain areas or social distancing, things will turn around even when you started late. So Italy and Spain started quite late, but they were still able to kind of contain the epidemic unfortunately, after losing a lot of lives. If they had started early, like Germany or South Korea, they might have averted a lot of unnecessary deaths. US, on the other hand, is still very stubbornly refusing to give out a strong, unified message of social distancing and isolation. And there are parties happening in the US in many cities, festivals happening, and gatherings happening, and they're still transmitting infection. And they will be, unfortunately, lose a lot of lives unnecessarily before they start to control this epidemic. Pakistan, as I mentioned, has an up and down curve, and this is most likely related to the number of tests being done on any given day. If we have a steady stream of tests, I think we will be able to get a better picture. I don't have a better picture of that because those data are not available to me. But we are hoping and we are praying that with the strong messages of social distancing, and targeted lockdowns of certain areas where the risk is very, very high, we will be able to stem the tide. So in summary, the pandemic is on the upswing in some parts of the world. However, the good news is that China, South Korea managed to stem it relatively quickly. And now we have seen that Italy and Spain have seen a plateau, which means that public health measures do work. But for public health measures to work, the governments must provide unified and clear advice and enforce those measures. But we as public also have to take responsibility and not do risky behavior, because we put not just ourselves at risk, but everyone else around us at risk. So I will stop here. It has been about 50 minutes. I wanted to give some time for questions and answers, because every time we do this talk, we have a very large number of questions that come up. I will hand it back to the moderators to moderate the questions however they would like to do that.
Thank you very much, Professor Bhatt. We had a wonderful presentation from you, and it also covered so many important aspects which have been going on, in our minds. So you dispelled a lot of myths. But at the same time, we have a huge number of questions, and we're going to have some of them, but we cannot answer all of them because it's such a large number. So I hope that those who ask the questions would not mind, because of the time constraints, we would be taking a few. So, so the first question that came was by Dr. Imran Khadir, and he is asking, is it safe to conduct elective surgical lists? And
so yeah, there is a certain amount of risk associated, because you never know who is positive, particularly when the rate goes up and you're not testing a lot of people. Most countries in the world have stopped elective surgeries or curtailed them very, very significantly. This is what I would also recommend, that if any surgery that can be postponed should be postponed. Serves two purposes. One is it cuts down the risk to your staff, because remember, intubating a patient puts the anesthetist at a very high risk. Secondly, you will also save ICU beds, because most patients who undergo major surgeries require a step-down ICU bed for some time. So you want to save those for patients who are very, very sick with coronavirus disease.
Thank you. There was another question which kept coming up again and again was, what is the asymptomatic period of the virus?
So anywhere between day 0 to day 5. So incubation period is a median of 5.2 days or so. About a quarter of the patients remain asymptomatic and do shed the virus during that time. So it can happen up to 5 days. In some cases, maybe as much as 14 days, which is the upper end of the 95% confidence interval. So asymptomatic patients are a significant source of transmission of infection.
So another question which is coming up again and again is that how long does it stay on paper? And then the other question alongside was, in China, the PPEs that they used were 5-layered, but those in Pakistan are only 2-layered. This was from Dr. Muhammad Arshad from Mandi Bahauddin. So what is—
I missed the first question, Dr. Shaila. What was the first question?
How long does it stay on paper?
On paper, and no one has done, I haven't seen data, but on cardboard, it can stay up to 24 hours at least. So I would extrapolate that paper would be something similar, that at least 24 hours or so. In terms of PPE, I don't know the number of layers, but the N95 mask is what the gold standard is for preventing these sorts of infections. They are made of a certain material, and they have respirators in them. We do understand, unfortunately, most countries, including Pakistan, do not have enough equipment, PPE right now. But the good news is production in China has started, and they're starting to ship out very large number of masks and gowns to the rest of the world.
So there is one other associated question which comes from our general practitioners. They are asking, what precautions should practitioners adopt while doing OPD? Should we use full PPE?
First of all, if there is any way you can do via telemedicine or video or phone, any patients who can be taken care of via video or audio should be taken care of like that. If they have to come to the OPD, the first thing you need to do is you need to have hand sanitizers at the entrance and every possible place. They should be distance where they sit in your waiting area. And then when they come into your room, yes, I would recommend wearing at least a surgical mask. What you can also do is you can put a surgical mask on every patient who comes into the room, because that is likely to help you more than you putting on the surgical mask, because there is less evidence that surgical mask prevents you from getting infection. There's more evidence that it prevents people from giving infection. So those are the 2 or 3 things you can do. But then also clean surfaces wherever the patient touches, your desk, your chairs, etc. Clean them with a chlorine-based or an alcohol-based solution frequently.
Okay. Now, before we take any more questions, we're going to take some viewpoints from Professor Altaf Alam, who's a gastroenterologist and hepatologist, and Professor Altaf Alam. So
you might have to unmute him.
No, he's already unmuted.
Okay.
So in case he's away, I will. Let's see.
Thank you once again, Adeel Saab. What a wonderful talk covering all the day-to-day problems and questions that keep on arising in our minds. You know, we have this, the problem that you discussed in Pakistan, the graph shows up and down. You are very right that we are, you know, we screen, say, 400 people from Tablighi Jamaat who continue to get together despite the sanctions. And when we check them, high number turn out to be positive. And then so on and so forth, people coming from Iran and, you know, other parts of the world as well. So that explains the bumpy slope that we are seeing for Pakistan, which is not a true reflection that, you know, the pattern is changing every day. It is not. It is just that we are testing a cohort of people who are more likely to be positive, and that's why that the graph that we see. I won't take much time. A wonderful attendance, which is, and I thank all the participants for sparing time, more than 800. It has never happened before. Wonderful, really, to have so many people attending this very, very useful talk. Thank you, Adeel Bhatt Saab, and thank you, participants.
Thank you, sir. You are my teacher, so I learned from you.
Thank you very much, Professor Altaf Alam Saab. It was wonderful hearing you. May I request Professor Bilal Muhyiddin to please, he's a professor of cardiology. So Professor Bilal Muhyiddin.
The co-host has asked you to start. Baba,
So till we have Professor Bilal Muhyiddin, we can just go to Professor, we'll take him later because he's not available right now. So Professor Arif Mahmood, who's a gastroenterologist.
How are you?
Okay, we have Professor Bilal here. Hello.
Yeah. Fantastic meeting, I must say. I had to just step out for a second. I needed to go. It's a subject that, as a cardiologist, we are facing it a lot. And with this chloroquine, etc., business that has come up, the problem is that the COVID itself causes myocarditis, It causes dysrhythmias, and the same effect is true for also the quinine and all of these mycines that are coming up. The rampant information that is going around, it's really creating a lot of confusions. The way I have sort of gone out to say is that so far, we don't have a hard, fast evidence saying that we can do it. All we can have is that this is something which is an option on the desk for us, but we have to take this with a pinch of salt. A very interesting example a friend of mine came up with was that how strange. We have BCG, which is a bacterial issue, a malaria, which is a parasite issue, and a virus. Yes, there is lymphocyte stabilization and all of that stuff is there, but in which direction we are moving, that is a question. But thank you for a lovely talk. And as far as, that whole myth about a virus coming up, being created, etc., being distributed, people who are believers of that theory, the one thing one is always is amazed that this jet age has been able to do. Look at the way the virus has spread. This is a jet age problem. Whether this was designed at a certain at a stage to see whether how humans will react to something like this, that we really don't know. But one thing is for sure now: the medicine of tomorrow is going to change as of now. Things are now changing. It's the 9/11 of medicine which has happened now. So we all have to now, once again, go back to the basics. The basic drawing room, the basic drawing board has to be reintroduced. Learn to wash your hands. Learn to use the non-touch technique of living. Of course, for doctors, that is impossible. You have to feel the pulse. The telemedicine is a good option, but since you can't touch the person, the human touch is the one that actually everyone loves for, dreams for, and that is exactly when we say that a good history makes a difference. So these are my comments about the whole thing, and I really hope and pray that we are able to jointly fight this out, because an old statement goes, united we stand, united we rise. Thank you.
Thank you, sir.
Thank you very much, Professor Bilal Mohideen Sahab. May I request now Professor Arif Mahmood, who's a professor of gastroenterology and hepatology, to give his views.
Assalamu alaikum, everybody. Adeel, a wonderful, wonderful lecture. Just all very proud. You touched upon very pertinent questions and answers them very nicely. Two questions from my side. Is there any propensity for the virus to mutate slightly and become less dangerous? That is number one. We feel that there are two types of strains going around in the world. The other is, what is the mechanism of plateauing out and then going down? Is it an innate immunity which develops a herd immunity, or are there any other things, or we don't know anything about it?
So as far as your second question is concerned, to develop herd immunity, you require about 70 to 80% of the population to be infected and develop antibodies and immunity. So I think it's very early on in terms of herd immunity to take any effect. So that is where, and we hope we never get to that stage where we infect 80% of the world's population, because remember, the mortality is somewhere between 2 to 4%. If you infect 1 billion people, you'll have hundreds of thousands or a couple of million of extra deaths, which you don't want. In terms of viral evolution or mutations, we haven't seen that so far. A paper or a commentary came out just today. I read it about 2 or 3 hours ago. People have not been seeing that major mutations so far. There are 2 strains, you're right, the S strain and the L strain, and one is more severe than the other. That may partially explain why some countries have less severe disease, but we'll need to do a lot of genetic sequence or gene sequencing of the virus to understand that and correlate that with the symptoms. Another question that comes up very frequently, that follow-up is if you get infected once, will you get infected another time? Would you develop immunity? So it's too early to say for COVID-19, but for coronaviruses in general, MERS and SARS, the immunity is long lasting, so you don't get reinfected. There was one patient in Japan who was reported to get reinfected, but we don't know the details of that. Was it a false negative in between, and then he became positive again, or something else happened? But generally, the consensus among virologists and infectious disease doctors is that you develop immunity to this.
Thank you.
Thank you, sir.
Over to Dr.
Dr.
Shella.
Shella, your mic is off.
1 minute. So, thank you very much, sir. Now we have with us Dr. Asad Chaudhary, who's a consultant gastroenterologist and hepatologist. So, sir, can we have your viewpoint?
Thank you very much, Shala and Dr. Adeel. But as it has been wonderful to have you amongst us, and we'll keep you seeing in our experience with you with Project ACO meetings has been wonderful, and today again a wonderful session. There's always to learn, and we look forward to you. I think to be engaging you in future for sessions also. Thank you very much indeed. Thank you, Ferozsons.
Pleasure and honor, Dr. Chaudhary.
So then we have Professor Zahid Yasin Hashmi Saab. Sir, can we have your viewpoint, please?
I think I'm just trying to connect.
Hear your voice.
Yeah, can you hear me?
Yes.
Yeah, thank you very much. I think it was a very wonderful experience, and I'm sure everybody has enjoyed like myself, and feel so honored and so grateful to Ferozsons and to Batsab for making such a useful and I think it was an excellent presentation. Thank you very much. Thank you.
Thank you, sir.
Thank you so much.
Thank you very much, sir. So a few more questions, Professor Bhatt. There's another one which says that sewerage contamination of the virus, and how long is it viable in the sewerage?
I have not come across any study in sewage. The virus does get excreted and picked up in stool. Excuse me. So people have raised the possibility that fecal oral route may be a way of transmitting the virus. We just are waiting to see. But virus in the stool is viable, so it can transmit infection. But again, goes down to meticulous hand hygiene will prevent that.
So we would have to prevent the fecal-oral contamination as we do with other diseases, and that's again back to the
back to the basics. Yes,
yeah,
absolutely.
Basics.
So
and then there is another question which asks, does the use of steroids make the patient more prone to COVID? This was asked by Dr. Yasir.
So no controlled study has been done, but anything that depresses your immune system will increase your likelihood of getting more severe infection. So yes, I would say that steroids should not be given to any person unless it's absolutely needed. Steroids should not be given to people with COVID-19 with mild or asymptomatic disease. They are reserved for patients with severe refractory hypotension who are in the ICU and require steroids to bump up the blood pressure. So very, very specific situation where steroids may be helpful. Otherwise, it's a general no, do not give steroids. That will increase the risk. It will also increase the risk of secondary infections.
Another question from Dr. Arif Mehman is, what is the possibility of producing aerosol from asymptomatic or mildly symptomatic children who are unconfirmed cases when they are crying during routine examination and vaccination?
So if they are unknown, then I can't really say. But if they're diagnosed cases, or if you know they have infection, then aerosol generation is very real. It happens. Even in asymptomatic people, it happens. And those aerosols, the virus can survive in that aerosol for up to 4 hours.
We have Brigadier Kassar Khan with us who wants to ask you a question. So Brigadier Kassar, can you please state your question, sir?
Assalamu alaikum. Can you hear me?
Walaikum salam. Yes, sir.
In cardiology, because we know that one of the complications is myocarditis. So we can have patients for non-specific chest pain and ECG abnormality. So we have to treat all patients, whether we know the status corona positive or not, as if we are dealing with a corona positive patient. So elective angiograms we have stopped. We are only going for an emergency cath, and we take all the precautions as if we are handling with a corona positive patient. So we have to be very, very careful. And today's session was very illuminating, and we have learned a lot from you, sir. Thank you very much, and we are all grateful, and we are still learning from each other's experiences.
Thank you. And I fully agree with you. You have to treat every patient at this point in time as if they were positive, because the growth is exponential in most countries. In countries like Pakistan, we are not testing enough to understand the full epidemiology. So you have to be even more careful.
Thank you.
So I must thank Brigadier Saab for your comments. They were very, very pertinent. Thank you very much. So may I now request Professor Taj Jamshed for his comments, please?
Yeah, Assalamu alaikum. Thank you very much for asking me to join this excellent meeting. I must congratulate Dr. Bhatt for giving us the nice presentation and really clearing up some of the myths which are already there in our doctor society. The point is just because you see in Pakistan, we have seen a lot of people, they are using these face masks. So I just want your comment about this, these face masks of different colors and different fashions, and what's going on? Is it really helpful for us people, or just the surgical mask? I know being doctor, surgical mask more, but I just need your comment. And I must say at the end, thanks to the Ferozsons for giving us the opportunity. Dr. Bhatt, if you can just...
Thank you, sir. Excellent question. So I'll separate that into two parts. So one part is about the scientific evidence that we have with the use of face masks like surgical masks. And second part is what does common sense tell us? So the scientific evidence is that if you use surgical face masks, you will decrease the generation of aerosols and viable virus that will be transmitted. I showed you an elegant paper which was published yesterday. So surgical masks may prevent or cut down the amount of virus by 70 to 90% or so. And that is substantial. Where there is consensus among infection control practitioners and the infectious disease doctors is that surgical masks are better for symptomatic people to stop the transmission to other people. They're less effective if you put it on yourself to try to prevent yourself from getting it from someone else. So in other words, if you have a mask on your face and someone in the room with coughs onto your face, you're more likely to get infection. In that situation, it's better that that person wears a mask than you wear a mask. I hope that explains what I'm trying to say. The second part is if you don't have enough equipment.
Sure.
If you don't have enough surgical masks or N95 masks, लोग कपड़े के मास्क पहन रहे हैं, लोग टिश्यू पेपर बना के पहन रहे हैं. So there because scientific evidence is lacking, I would use common sense. I have a feeling it will not prevent as good as well as a surgical mask, but perhaps 10%, 20%, 30%, which is still better than nothing. So I would say, if someone wants to wear it, please go ahead, but don't fall into false security that because I'm wearing that non-approved mask that I'm protected or I will not infect other people.
Thank you. Thank you for your response.
Thank you very
Hand over
much,
to Shaila.
Professor
Thank you, sir.
Tamshid. Thank you so much. And Dr. Mariam Arfin, we have your question, please, now? Dr. Mariam Afreen. So since we seem not to be getting connected with her, may I request Dr. Jamilur Rahman, please? Dr. Jamilur Rahman, sir, you had a question, I believe. So since we seem to be having lost them, there's another question which is everybody's asking. How long will it last in Pakistan? And when would our lives be normal?
देखिए जी, ये तो भाई सिर्फ अल्लाह में ही बता सकते हैं। हम बशर के बस का काम तो नहीं है ये इतनी बड़ी prediction करना, but Allah has given us some sense and some knowledge. He has bestowed some knowledge upon us as his viceroy, as Ashraful Makhlukat. So we need to use that knowledge to make sure that this duration is shorter. और क्या चीजें काम करती हैं? We discussed that in the lecture, that social distancing, physical distancing, and targeted lockdowns. So in other words, if you have an outbreak in a small area, you figure out what area do you need to quarantine and so forth, and you do that. Now, there are, of course, other considerations, economic concerns about food security and other things that need to be taken into account, and those need to be taken at a higher level in the government. If we do that, the data is relatively clear. If you have a mortality rate of less than 0.2 per thousand, and you institute all those measures, you might very well abort the exponential rise. If you miss that, if you start instituting those measures after that, then you will see what Italy and Spain and the US are seeing. If you remain stubborn, even after that, you'll be what US is right now. If you come to your senses, it'll be like Spain and Italy, where they saw exponential rise, but now they've seen a plateau, or in Italy, it even started to come down. So it took them about 4 to 6 weeks to come to that point. But that was after very strong national measures. Without that, there's no way to predict what will happen. If you take those strong national measures uniformly applied, then I would expect somewhere around 4 to 8 weeks or so.
Okay.
But it took plateau.
Okay. So there was somebody is also asking whether dead bodies, how long are they infective, and the dead bodies of corona patients, how contagious are those?
So if they have been infected, you have to treat them as they are source of transmission till the time they are buried. And obviously, when you wash them, or the thing is different in different places, the washing technique is different. मैयत को गुस्ल देने का तरीका, कुछ वो प्रेशर वाले पानी से करते हैं, कुछ रेगुलर पानी से वो बर्तन से डालते हैं. If you generate pressure hose के साथ पानी करेंगे, you will disperse the virus and have a higher chance of infecting other people. You have to treat every mayyat as if they are infected. If you know the cause of death, then definitely take extra precautions. You have to be in full PPE to bury that mayyat.
Okay, thank you very much. May I request Professor Dr. Bashir Hanif to have his comments?
Can you hear me?
Yes, sir.
Adeel, Assalamualaikum. Bashir here.
Walaikum assalam, Dr. Saab. How are you? Good to see you.
I'm good. How are you?
Alhamdulillah.
Excellent talk, and really enjoyed. I'm glad that you were able to actually bust most of the myths. A lot of people have it. I know one thing which is actually I think will be good for all of us is that, and I hope and pray for you also to stay safe in New York, because that's the worst hit area right now in USA. Like, what kind of precautions you would recommend taking for the healthcare workers who come home after going to the hospital? Obviously, healthcare workers have to go to the hospital and they can't stay home. So when they come back home, unfortunately, if God forbid you get exposed to an asymptomatic person, and then you anyone can have like asymptomatic and have a virus, so you want to make sure that you are not affecting your family members at home. So what kind of precautions you would suggest, or what kind of precautions you are taking when you come back home from the hospital after seeing the patients?
So that is an excellent question. I'm glad you asked that. Maybe I should use that in the next lecture as well. If you have resources, or if you're able to do that, this is what I would recommend. When you leave the house, you get to the hospital, you change into different set of clothing, preferably scrubs. You use those scrubs for the duration of hospital stay. When you leave the hospital, you either change in the hospital, or if there's no way, you have to come back in those scrubs. Ghar pe pahunch ke, first thing you do is you go to a separate room, take those scrubs off, take a shower, meticulous hand hygiene, sabun say, with soap, shower, and then change into home clothes. So in other words, those clothes should not come into contact with the household items. That also goes for shoes and socks and any piece of clothing that you wear. So this is what I would recommend, and a lot of us are doing that and advising that. So separate your clothing, hospital versus home, and there should be a physical barrier when you change them, so that nothing at home comes into contact with what you wore at work.
Thank you very much. It was a great talk.
Thank you.
Thank you, Professor Bashir Hanif. Now we have Professor Abdul Rashid Khan Sir. Sir, can we have your comments?
Thank you very much. This is a really excellent question. And my question was almost the same which has just asked by Dr. Bashir. How we should prevent ourselves with the hospital environment coming to the home. So because I've been forced to come to the hospital because to see the certain patient. Number one. Number two, I have a question that do we need to screen the patient before going for intervention, like for angiography or angioplasty? So if the patient is negative, so can we go ahead for intervention or not? Thank you very much.
Thank you for the question. So I think part of that is an answer that if it is elective, see if you can postpone it. If you really need to do that, then you treat every patient as potentially infected. If you have the ability to test, you can do that, but you'll need to do a PCR-based test, which takes several hours to come back. So if the patient is on the table in an emergency situation, you wouldn't be able to get the result in time. The other way to do that is do the antibody-based test. The problem with that is that the antibody-based test, although the result will come in half an hour, but patient may not have developed the antibody for up to 5 to 7 days after being infected. So they may be infectious with the test still being negative. So treat every patient you put on the table as potentially infected, क्योंकि जो प्रोसीजर करने वाले बहुत एनेस्थेटिस्ट और सर्जन के लिए रिस्क बहुत ज्यादा है, खास तौर पे एनेस्थेटिस्ट के लिए, because they're intubating the patient.
Thank you. Thank you.
Thank you, sir.
Thank you very much. Thank you, sir. I would like to thank the Society of Gastroenterology and Hepatology for joining hands for doing such a wonderful program today, and so well attended. And I would now request Mr. Usman Khalid Haid Saab, who's the president of Ferozsons Laboratories Limited and CEO of BF Biosciences Limited. He has got a very keen eye on epidemiology and strategies, different diseases. So I would request him to please come forward for the vote of thanks, sir.
Thank you very much, Dr. Shaila. And I would like to start by really profusely thanking Professor Adeel Ajwad Bhatt. I don't think we can thank you enough, Dr. Saab, for repeatedly
Always a
coming
pleasure.
and spreading the message of knowledge and science in the face of what is a lot of fake news and oftentimes very harmful fake news that we have to fight at the same time as we are trying to fight this pandemic. At the peak of the talk today, we had almost 900 participants. So I'm really grateful to all the people, some of the very senior people who have given their comments, asked their questions, but also all of those who did not get an opportunity to participate actively through questions or comments, just because of the shortage of time. We are so grateful to be part with you in this noble mission. Our motto has always been putting patients first, and I think all the physicians who are on the audience today, there is no better exemplification of putting patients first than putting your own lives at risk and going to your hospital or to your clinic every day and still trying to work for improving the quality of life of the patients that we all are here to serve. So a big vote of thanks again to everybody who participated, and especially to Professor Adeel Ajwad Bhatt, who right now I know has very pressing research assignments that he has to rush back to. He's also advising the government of Qatar on their strategy for COVID-19. But in all of this, his heart is, of course, back in his home country in Pakistan, and he takes time out repeatedly again and again to come online, to answer our questions, and to really enlighten all of us with the wealth of his knowledge. So thank you once again, Professor Adeel Ajwad Bhatt, and everyone who participated. Thank you from the bottom of our hearts.
Always a pleasure. Thank you for arranging that.
Thank you.
So thank you so much. Thank you very much, everyone. And I think we will be concluding now. Thank you very much, Professor Bhatt. It was wonderful listening to the so well prepared presentation with so much research and so much pertinent research. Thank you so much, sir. It was a pleasure.
Thank you.
Thank you.
Assalamu alaikum.
Thank you very much, audience.